Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is a nice example of a rare benign tumor of the breast, which is mammary myofibroblastoma. This is a case of a 50-year-old female patient who noticed a non-tender mass in her left breast, from which a biopsy was taken. And as you can see here from the low power magnification, this is a spindle cell proliferation. It is pink in color. So we have spindle-shaped cells arranged somehow focally, at least in a storiform pattern. And remember, it's a pink in color rather than a blue in color, and showing minimal pleomorphism. Now, on intermediate power magnification, you can see again some storiform growth pattern, but the cells in general are bland looking, and we have a lot of collagen in the background in between the tumor cells. On a slightly even higher power magnification, you can again see the spindle-shaped nuclei, in general minimal pleomorphism, and these are intersected by collagen fibers that are produced by the tumor cells, and other areas showing again the more bright acidophilic collagen fibers is intersecting in between the tumor cells, which are showing here some fascicular growth pattern, not much in the way of pleomorphism. There was no evidence of mitosis, and there was no evidence of necrosis. Extremely important for the differential diagnosis. And yet other areas showing again perhaps some tendency at vague storiform pattern, but the collagen fibers are clearly present here. In some areas very focally, there was some tendency at palisading, bringing a neuronal tumor, something like schwannomas, into the differential diagnosis. At the very edge of the tumor, some entrapped fat might suggest some infiltration into the adjacent breast tissue, but there was no evidence of entrapped ducts or lobules in the biopsy. So based on the morphology, the differential diagnosis is really vast in this case, and would include myofibroblastoma, mammary myofibroblastoma, but also would include something like low-grade spindle cell carcinoma, which is an aggressive type of a tumor, would bring into the differential diagnosis because of the vague storiform pattern. Dermatofibrosarcoma would bring solitary fibrous tumor into the differential diagnosis. So now we really, in a way, established our differential diagnosis. We want to use our immunohistochemistry. And the first immunohistochemical stain that was used was CD34. And as you can see, this is diffusely positive in the tumor cell cytoplasm. But this would not really narrow the differential diagnosis, because we know that many entities like the myofibroblastoma, like the DFSP, like the solitary fibrous tumor even can be positive for CD34. Now, Desmin was also positive, and this really, in a way, would favor mammary myofibroblastoma over other differential diagnosis, but we have to use other immunohistochemical markers in order to rule out the rest of the differential diagnosis. Remember that low-grade spindle cell carcinoma can be very bland looking, and it has to be ruled out, especially with the age of the patient. So we have to use multiple cytokeratins, multiple pan-cytokeratins, like the AE1, E3, the CAM5.2, the MNF, even EMA, and P63. Extremely important to rule out the very different diagnosis, which is the spindle cell carcinoma. This is an aggressive type of a tumor with different way of management. Because of that, we have always to have it at the back of our mind, and we have to always rule it out. STAT6 is negative, and this tends to rule out solitary fibrous tumor. Remember that the tumor was CD34 positive, but also Desmin positive, which means this rules out the FSP. And important consideration, but also even with the H&E, because of the pink color of the tumor, DFSP usually is blue in color because of the high cellularity. In a way, this comes at the very end of the differential diagnosis. So the final diagnosis in this case is mammary myofibroblastoma. This is a benign tumor that is cured by excision. This is why it's extremely important to sort out the differential diagnosis, the most important of which actually is spindle cell carcinoma. Because of that, we have to apply a large panel of epithelial markers, including cytokeratins, EMA, and P63 to make sure this is not spindle cell carcinoma. Other differential diagnoses are DFSP, which is ruled out by the positivity with Desmin, and solitary fibrous tumor, which is ruled out by the negative staining with STAT6. Remember that similar tumors can occur outside the breast, and these are called extramammary myofibroblastoma. One of the areas that commonly is involved in this type of tumor is the scrotum. So whenever you encounter a similar case, a similar morphology in the scrotum, it might be actually an extramammary myofibroblastoma. The combination of CD34 and Desmin immunohistochemistry helps to sort out the diagnosis. I hope you find this tip useful in your daily practice. Thank you.